and welcome to this month's podcast, bringing you up to date with the latest research in axSpA. We are going to review two papers with my co-hosts, Hideto Kameda, Atul Deodhar, and Xenofon Baraliakos. We will discuss switching to secukinumab or cycling with other TNF inhibitors in patients with axSpA and long-term safety of bimekizumab in patients with axSpA or PsA. To access detailed summary slides for the papers discussed today, please visit imidforum.com. And now we will start with the first paper on the best option for axSpA patients after first TNF inhibitor failure, switch to secukinumab or cycling with other TNF inhibitor. And Atul, over to you, please.
Yeah, thank you, Sofia. This is an important clinical question. What do we do when the patient with axial spondyloarthritis have failed or have had inadequate response to the TNF inhibitor? So this paper comes from, the study is done in Turkey, which is the best option for axial spondyloarthritis patient after first TNF inhibitor failure. Should we be switching to secukinumab or should we be cycling with another TNF inhibitor? So as we know, in the introduction, the authors say that the aims of axial spondyloarthritis treatment are controlling symptoms, inflammation, prevention of progressive structural damage, preservation of functionality, and maximizing health-related quality of life. It's a chronic disease and the treatment is lifelong. Patients may need to remain on this treatment for a long time, lifelong. So a high long-term drug survival rate is very important. There are a few studies in the past which have looked at this drug survival, but not many to see what should be done ideally when somebody fails or has inadequate response to TNF inhibitor. Should we be going to another TNF inhibitor or switch them to IL-17 inhibitor, in this case, secukinumab? So Kaya et al., this is a Turkish group, they evaluated drug survival of TNF inhibitors and secukinumab as a second-line biologic treatment. And they set to determine the subgroup of patients who might benefit by either switching to another TNF inhibitor or to an IL-17A inhibitor in terms of drug survival after the first use of a TNF inhibitor. This was a retrospective analysis of a database that they had, and they looked at the clinical characteristics and laboratory results when the patients switched after failing their TNF inhibitor to either another TNF inhibitor or to IL-17 inhibitor. And the clinical characteristics and lab parameters were comparable between the two groups. And interestingly, there was no significant difference between the two groups when the drug survival was evaluated. So to see whether the drug is the second TNF inhibitor or the IL-17 inhibitor is effective or not, they used drug survival as a surrogate. And they found out that there was no difference whether they switched to TNF inhibitor or IL-17 inhibitors. However, they wanted to do this subgroup analysis, and they found out that CRP level, high CRP level, and primary failure, those were significantly associated with the risk of discontinuation of a second TNF inhibitor. And that kind of the primary failure, I think, is obvious. We generally would switch to another class of drugs, and that's what they found. Smoking and Achilles tendonitis was associated, Achilles enthesitis, I should say, were associated with the risk of secukinumab discontinuation. So in conclusion, they say that it's pretty similar whether you switch the patient to alternative TNF inhibitor or secukinumab when somebody has failed first TNF inhibitor. However, secukinumab is a better option in patients who have experienced primary failure of a TNF inhibitor, and that is not surprising. Whereas alternate TNF inhibitor may be preferred if there is Achilles enthesitis and actually smoking, patients who are smoking, then it is preferred to switch to TNF inhibitor. And this is just association. But the first part, the primary failure, that kind of fits our clinical practice. So I would just open it to see what other comments you would have.
Thank you very much, Atul. I can give a start and then hear our colleagues as well. I think it's, as you have started by saying, this is a very important question with application in our daily clinical practice. We are always seeking to know which drug we should give to which patients and which are the best candidates for each of the drugs, because that allows us to identify responders to each drug, of course. So especially after failing TNF inhibitors, we do not have trials in which two active drugs are compared. So that means we have to rely on data from observational studies. I have to say that the first thing that comes to my mind when we look at data from observational studies is the problem of confounding by indication, is who are those patients that have been selected to be treated with an IL-17 inhibitor or with a TNF inhibitor after failing a TNF inhibitor. And it's true that the authors show us the baseline characteristics, and we do not see differences between them. So it seems that the groups are relatively balanced. But I think we all know from our daily clinical practice that there are often factors that can influence the decision and that are not always measured in these typical baseline characteristics that we see in the papers. So that means that having that confounding by indication not adjusted for is an important issue. And I don't think that there's a miracle solution to adjust for confounding by indication. So there are always challenges with interpretation, but there are analytical techniques that can deal with some part of confounding by indication. And if I understand correctly, the authors have not used them in this paper and have simply looked at comparisons and predictors of discontinuation and in each of the groups. So I think this is a point to raise attention, and I see that you are agreeing with me. That is something, a limitation of this paper that I think we have to emphasize, because then when we go to the next step, which is when they have identified some predictors of response or lack of response in each of the groups, I think that it is an issue that these predictors have been identified in an analysis that has not been adjusted for confounding by indication. With other words, do I go tomorrow to my clinic and I think that CRP and enthesitis of the ankylosing enthesitis or smoking are really the predictors of response or lack of response? I think we have to be quite a little bit careful. It's good to have these findings. It's good to consider them, but I think we have to be careful in immediately thinking that this gives us the clue. I'm curious to hear your thoughts about this.
Yeah, one quick point. So there is a similar older study, about 5 years old, 2020. This is from the Swiss clinical quality management cohort. And 5 years ago, we did not use IL-17 inhibitors as much as we use them now. And of course, the study was published in 2020. So they actually looked at this patients in that Swiss clinical quality management cohort even before that. So that's, and they also are looking exactly at the same question: effectiveness of secukinumab versus alternative TNF inhibitor in patients with axSpA previously exposed to TNF inhibitor. And they, in that particular study, their statistical analysis is slightly better in that they did matched weighting propensity score to match the two groups. That is one point. And the second point is, here in this Turkish study, they used drug survival, and which is fair as a surrogate marker. In the Swiss clinical quality management cohort, they actually had data about the BASDAI at the start and at the end. So they were looking at BASDAI 50 in patients who switched to secukinumab, and what percentage of patients had BASDAI 50 at 1 year after switching, and what percentage had BASDAI 50 response at 1 year in the TNF inhibitor switching. So those were the slight differences, but interestingly, the conclusion is the same. There again, they found out that the effectiveness of secukinumab is switching to secukinumab is as good as switching to another TNF inhibitor in that study as well. And I fully agree with you that there is this confounding by indication. The other thing is this primary failure, secondary failure, just take the word when you're looking at the retrospective analysis. Difficult always to know whether it really was a primary failure, secondary failure. I mean, so the only way to look at this is prospective study, and only do it on secondary failure patients. I mean, primary failure, it is obvious that the patient is probably not going to respond. So secondary failure would be a good thing. And the third point quickly I want to make is in US, we cannot use JAK inhibitors unless somebody fails anti-TNF. And so that's another class that we have. So a study ideally would be to, three-pronged study. Somebody fails TNF inhibitor, then prospectively give them either a TNF inhibitor or a JAK inhibitor or an IL-17 inhibitor in the secondary failure patients, and follow them prospectively to look at their ASDAS and BASDAI and other things rather than just drug survival.
Yeah, I'm happy you brought in the Swiss study because it's exactly what I had in my mind and I was going to mention as well in contrast. So the analysis contrasts to what I was mentioning here, that
Yeah.
no propensity score was used and no adjustment for confounding by indication. Indeed, that was conducted in the Swiss cohort, and indeed the results are similar. From what I remember, they indeed looked at efficacy, as you were mentioning, the BASDAI 50. They also looked at drug survival, and the results were similar. And so indeed, that is convincing when we see the same results across different studies.
Yeah. That study, the one another thing was because it was done so, because it was, I mean, it's published 5 years ago. Patients who got secukinumab had received two or three, or something like that. I mean, they had, that was a second line. It wasn't second line, it was third line or fourth line or something drug. In other words, patients who ultimately ended up onto secukinumab in that time period and in that study were those who had failed not one but two or three TNF failure. I mean, this is what I remember. So that's another thing, that after one single TNF failure, then you should see whether they go on to second TNF or whether they go to secukinumab. That also needs to be clarified in the manuscript, that this really is one single TNF failure, not two. I mean, the longer multiple drugs, when patients fail, then they get more and more resistant, is our clinical observation anyway. So.
And I think your point about the primary or secondary failure is also a very important one in this context, indeed, and in the lack of better evidence. Maybe we can discuss a little bit what we think about it and what we do in our daily clinical practice. I think it's indeed different if a patient has had a primary or a secondary failure. If a patient has not really responded, has a primary failure and has never responded to a TNF inhibitor, we nowadays have a different reality than 5 or 10 years ago when we have more drug classes available. So, admittedly, in the lack of strong evidence, but I think it makes sense to give a chance with a different mode of action, which
Yeah.
probably has higher chances that a patient would respond. What are your thoughts about this?
Yeah. Um, Several years ago, we looked at another study, and I don't have that in front of me, but this was a multinational study, again, retrospective, and we just interviewed rheumatology patients, well, axial spondyloarthritis patients, as well as their treating providers. And we found out, and again, this was published about 5 years ago, um, maybe 3, 4 years ago, but this was an international study done in Europe, as well as in North America, as well as I think South America. And we asked the patients, how many drugs have you tried and whether your disease is active or not in your mind. And this was just interviews. But the point I wanted to raise is patients stay on a treatment for a prolonged period of time, even though their disease is not controlled. And there are several factors. And we were pretty surprised that when the patient was saying, we looked at their past history, etc., they were not controlled for 6 months, 12 months, but they still stayed on the same drug. And something similar I found in another study from Canada, that patients stick to the same drug, even though they're not responding. They stick to the same drug for several reasons. Number one is maybe there is an inertia that they don't want to change the treatment, whether the inertia on the part of the doctor. There may be insurance reasons for that. There may be, oh, we don't have enough choices, so that's why I stick on to this, and you're a little bit better. Why don't we try a little bit more? Come again in 3 months and we will see how you're doing. Maybe we can get a little bit more response, and etc. So this primary failure, secondary failure line gets blurred in these situations. And that's the reason why these retrospective analysis is a little bit, I mean, it gives you some glimpse, real life, what happens on the ground. But to get real scientific evidence, we need a prospective study, as we have already mentioned, that somebody who hasn't gotten the ASDAS less than, well, low disease activity or inactive disease response as a target. And if you haven't done that, then okay, we are going to switch you either to this, switch to another TNF or IL-17 or JAK inhibitor or something like that. That's a better study, and without worry about insurance and this and that, and a specific time that you're going to give them 3 months to see whether they reach that goal post or not, the target or not. Sorry, I do want to give a chance to Hideto and Xenofon to speak as well.
Okay, thank you, Atul and Sophia. So this is a very limited sample size study. And also, as a TNF inhibitors, they included adalimumab, etanercept, many other TNF inhibitors. But for IL-17A inhibitors, just included secukinumab and did not include ixekizumab or others. Of course, bimekizumab, very recent. So I don't know, this study results are applied to other IL-17A inhibitors or other IL-17 inhibitors. And also, I found that the survival rate is not so good for both groups. So that is the problems. Thank you.
Yeah, 40%, that's a good point. 40% people came out of the study in less than 2 years, I think 22 months or something like that. And that is not surprising though, Hideto. Several studies have shown that we think our patients stay on the drug for long, but they don't. So the survival rate, drug survival, is not very good in axSpA patients. But good point. Thank you.
I mean, I don't have much to add, to be honest, because you've really covered all the topics. I also believe that there is a little bit of a different experience in different countries, and obviously this has to do with the different systems that apply for reimbursement. We know data where primary and secondary non-responders have done differently. We know data there has been no difference indeed. But what I would like to say is that for that study that was cited and discussed, that it is important to have more of those to really see what's happening around the world, and maybe also see how it's happening in different areas where we work more precisely. So I would really like to state rather generally that we need this information, and I haven't really come to a conclusion yet.
Yes, maybe it's time to move to another interesting topic that we will cover with the second paper. Hideto, please.
Okay, so the second paper is entitled Long-Term Safety of Bimekizumab in Adult Patients with Axial Spondyloarthritis or Psoriatic Arthritis, pooled results from integrated phase 2b and 3 clinical studies. As a background, patients with spondyloarthritis may develop extramusculoskeletal manifestations such as uveitis and inflammatory bowel disease, which are more common in patients with axial spondyloarthritis than in patients with psoriatic arthritis. Bimekizumab is a humanized monoclonal IgG1 antibody that specifically inhibits IL-17F in addition to IL-17A. This paper reports the integrated safety data from phase 2b and 3 randomized clinical studies, such as B-Agile, B-Mobile for axSpA, and B-Active, B-Optimal, and B-Complete for psoriatic arthritis, and their subsequent open-label extension studies are presented by indication to assess the longer-term safety profile of bimekizumab in patients with axSpA and PsA. The result shown is in the bimekizumab cohorts, treatment-emergent adverse events, TEAE, occurred at an exposure-adjusted incidence rate per 100 person years of 304 in axSpA and 246 in PsA. Overall, TEAE occurred at an exposure-adjusted incidence rate per 100 person years of 137 in total axSpA and 140 in total PsA cohorts. The exposure-adjusted incidence rate of TEAE decreased with longer exposure to bimekizumab, and the exposure-adjusted incidence rate of serious TEAE increased slightly with longer bimekizumab treatment, and the exposure-adjusted incidence rate of TEAE leading to discontinuation remained relatively stable over time. With longer exposure to bimekizumab across the phase 2b and 3 studies, the three most frequently reported TEAE were COVID-19, nasopharyngitis, and upper respiratory tract infections. The exposure-adjusted incidence rate for these TEAE decreased with longer exposure to bimekizumab, except COVID-19. Exposure-adjusted incidence rates of adjudicated definite probable inflammatory bowel disease, uveitis, adjudicated major adverse cardiovascular event, and adjudicated suicidal ideation or behavior were low. 4.5% 4.5% patients with axSpA and 3.7% patients with PsA reported more than one fungal infection TEAE, and for oral candidiasis, 1.8% and 1.4% respectively. So in conclusion, bimekizumab exhibited a consistent and favorable safety profile across phase 2b and 3 studies in patients with axSpA and PsA, aligning with previously established safety data, and this analysis revealed no new safety signals. So, bimekizumab demonstrated good tolerability with rates of TEAE comparable between axSpA and PsA cohorts, remaining stable over extended treatment periods. So now over to you, Sofia, for further discussion.
Thank you very much, Hideto. Happy to get the start on here. I think this is very important when we have a new drug. We, of course, don't yet have experience from daily clinical practice or accumulated in registries and observational studies. So long-term extensions of trials and analysis of safety, or here in this case from different trials, different indications, are very valuable because they can allow to identify signals, especially of events that don't occur immediately in the placebo-controlled phase, and that we can monitor that throughout time. It's very reassuring to read that there are no major signals and no major findings, and the adverse events that were identified are in line with what was previously known. I think what stands out is that the common respiratory infections that our patients that are immune suppressed with biologic or targeted synthetic DMARDs have, in terms of highest frequency. In this case of these trials, we had COVID for the logic temporal time in which the trials were conducted. And then I think a specificity of bimekizumab and of IL-17 is the fungal infections. So I think it's important to quantify that and to know that especially oral candidiasis was happening in both indications, so in axSpA and PsA, but the frequency was not high, and especially was higher in the beginning and did not increase with the cumulative dosage that patients were taking. So I think those are important points. Also, after more than 2,000 patient years in each indication, we see that there were no serious fungal infections in these patients, and that were mainly mild candidiasis that were treated with antifungal treatment, and in the vast majority of the cases, patients could continue on bimekizumab. So I think those are all reassuring facts that we are hearing from this important study. So I think these were the aspects that I wanted to emphasize that are very important to me. Maybe Xenofon and Atul can continue with their comments on this.
Well, yes, I'm happy to take that up and say that indeed there's no disagreement here. There cannot be a disagreement because indeed the data are newer than any other studies with bimekizumab. On the other hand, I believe we, in the meantime, do have some good experience with the drug. Not so much for a long period of time, but with I would say pretty many patients, because I believe that the drug has really was well taken up. And the most important thing is what you mentioned at the end, Hideto, that there's no new signal in the longer term observation in any of these relatively close indications. So I am confident that we have a drug which is relatively or good potent, but has no additional adverse events, things that we need to take care more than what we knew. I remind everyone the situation we had with secukinumab in the beginning with the issues that we thought we would be seeing. This means all those fungal infections that all of a sudden would come up, and actually nobody really saw. So I don't want to play things down, but I just want to say that giving the right drug to the right patient also ensures safety.
Yeah, I agree with everything that is said. The one of the important things that this paper also has shown is year to year. Is there a change? In the sense, does the risk remain the same, or does the risk get worse, or does the risk get better of some of these things? And one experience with this drug, bimekizumab, is that the fungal infections, which are candida, generally occur in the first year, and then it kind of goes down. And I'm struck by this finding because this is same thing we have seen with long-term studies, post-marketing surveillance, and 5-year studies that ixekizumab and secukinumab have undergone. Is that candidiasis occurs early on, and then late, if after a year, then the chances of getting candidiasis is less. That's the first point. And I completely agree with Xenofon that and you, Sophia, that for newer drugs, the more experience we get, because the rare side effects you will not see by just seeing 300 patients and 400 patients in the trials seen for 6 months or 1 year. You really need long-term studies, 5-year studies, and larger number of patients and post-marketing. That's when rare signals that may not be shown in the clinical trials are shown. And I just want to draw the attention of people who are listening to this, is that tuberculosis, which we know is a risk factor for TNF inhibitors, we did not know when the studies came out first, way back when. And tuberculosis, this is the kind of a post-marketing thing. We never really did when TNF inhibitors came out in end of 1998 and up to 2002, something like that. We never did quantiferon on those patients because we didn't know that tuberculosis is a risk factor. And after, I don't know, 500,000 patients or million patients were treated worldwide on all TNF inhibitors, then actually it dawned on rheumatologists that, oh no, there is a problem with tuberculosis. So that's where the importance of long-term data to be seen or follow up, including post-marketing, is important to see whether rare signals come up or not. And I mean, this is the start for bimekizumab, but we have got some experience with long-term studies with secukinumab. There is a 1 million patient data published recently. Ixekizumab has published long-term data. Of course, that is IL-17A alone. This is A plus F. But that's the importance of these types of studies, long-term assessment. And one last point is that when they start talking about percent, I'm a little bit not too happy about percent. It has to be exposure adjusted. So, I mean, if you follow somebody for, I don't know, 5 years, then in that 5 years, there are going to be more and more. I mean, the percentage keeps going up of infections and percent going up. But that's where the exposure adjusted incidence rate per 100 patient years is probably more important. And so I generally, when I read these papers, I look at that EAIR, exposure adjusted incidence rate, rather than percent. If it's a 6-month study, then fair enough, percentage is important. But for these types of studies, EAIR is more important than looking at percent. And one more last point is, yes, I mean, the upper respiratory infection and nasopharyngitis, each and every study has that as the most common side effect. I mean, that is neither here nor there. The COVID-19, of course, is mainly because these studies were done in the COVID-19 pandemic period. So that would be, it's not surprising that they had that. And I don't think that they looked at comparison with placebo. Did they? Whether, I mean, patients who were, because this is now long term, of course, not patients are not on placebo for this time, but they could have looked at what was the general public's COVID-19 infection rate in the community. Of course, this study was done in different parts of the country, or different parts of the world, where the infection rates were different. So COVID-19 also, I don't know what to make of that, those numbers that they talk about in this particular paper. Any other comments from anybody?
No, I think we are good, and we have discussed these things extensively. I'm happy to take up and do the closing statement, because I think we had a very nice discussion, in-depth discussion to these very important topics, both of them also clinically very relevant. So in order to view the full publications that we discussed, were uploaded this month, and to access our other podcasts and the resources, head over to the imeetforum.com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure you don't miss our podcasts in the future. And as always, please let us know what you think by leaving a review. Thank you for your attention.